Okay, the next talk will be by Dr. Abhilasha Baharani, Cataract with uveitis, what to do. Dr. Abhilasha is a senior uveitis specialist at New Retina, Hyderabad.
I thank Dr. Bali for this kind opportunity. Thank you, Dr. Malika Goel, for the kind introduction. I'll speak on cataract surgery in uveitis. Most of the time, this is the picture that we see. So cataract is the most common surgical indication in uveitis. It accounts for 40% of visual loss in these patients. 1.2% of all cataract surgeries are in uveitic eyes. About 60 to 80% eyes achieve a BCVA of better than 20/40. However, post-op best corrected is 1 to 2 lines worse than non-uveitic eyes. So in this talk, I'll cover preoperative assessment and preparation, intraoperative challenges and technique, and post-operative complications and management. So we have to juggle a lot of things when we are planning cataract surgery in these eyes. So preoperative preparation and risk assessment is most important. When there is no view of fundus, get a B scan done. Of course, we have to look for the vitreous if there is no cells in the vitreous, but also look for choroidal thickness, which is an indicator for activity of uveitis. Assess the visual potential. Look at the optic nerve. This is a case of multifocal choroiditis with optic neuropathy. After healing, there was a slight pallor in the disc, and when we did fields, you see a centrocecal scotoma there. So this has to be informed to the patient beforehand. This is another case of intermediate uveitis, and while we are busy looking at the snowballs, we might miss the glaucomatous disc here. So get a fields done, and before planning surgery, all this has to be informed to the patient. Pupillary response and color vision should be checked, especially if the patient is on anti-TB therapy. Assess the macula, look for scar. Wherever possible, as much as possible, get an OCT done. Look for a CME, ERM, and you might even see a full-thickness macular hole in these eyes. Now, post-operative hypotony is more difficult to manage than increase in IOP. So the indicators of post-op hypotony are intraocular pressure less than 6 millimeters even when the eye is quiescent. When there is seclusion pupil with a normal IOP, please get a UBM done. If you see ciliary body bands or fibrosis, please plan a vitrectomy in these eyes. When the inflammation is poorly controlled, then these eyes are also at risk of post-op hypotony. Timing of surgery is important. Ideally, the eye should be quiescent for 3 months, but this does not apply for Fuchs uveitis. If fundus is visible, wait for as long as possible for full control of inflammation. Please delay the cataract surgery as much as possible. If the patient is having even 6/9, 6/12 vision, we can wait to do the surgery in these eyes. Early cataract surgery is preferable to assess and manage posterior segment pathology and when advanced cataracts pose greater surgical challenges. Counseling is paramount. Please give realistic expectations to the patient about visual prognosis. Inform the patient that the surgery may take longer than usual and there is a possibility of delayed visual recovery. Many patients think that after surgery they need not take their systemic medications. Please inform them beforehand that uveitis treatment will go on even after surgery. So compliance is important. They should come for frequent follow-up. Many of these patients are quite young, and please inform that they'll need reading glasses after surgery. They should not be surprised that the reading vision is gone. So coming to preoperative preparation, steroid prophylaxis is for those who are at risk of macular edema or a recurrence or a hypotony. Step up systemic immunosuppression 1 month prior to surgery. Oral steroids should be given 1 milligram per kg starting 3 days preoperatively, and they should be tapered to the preoperative levels at 1 month. Local steroids, intravitreal or posterior subtenon or intravitreal DEX implant can be given when the uveitis is unilateral and when you know the etiological diagnosis. Please avoid local steroids in the absence of an etiological diagnosis of uveitis. So absolute and long-lasting control of ocular and systemic inflammation is most important in these eyes for satisfactory results. Do not forget to give prophylaxis for infectious uveitis like toxoplasmosis and herpetic uveitis, which tend to recur after cataract surgery. Choice of surgery is obviously phacoemulsification because it causes less inflammation. When cataract and glaucoma coexist, cataract surgery should be done first, because if a combined surgery is done or a glaucoma surgery is done first, the inflammation from cataract surgery can result in failure of the bleb. If cataract and retinal problems coexist, a combined surgery can be planned. Anesthesia is surgeon choice, but do not do these surgeries under topical anesthesia because there you can get surprises intraoperatively. I prefer subtenon anesthesia. It can be given with a single port cannula. So here you just see, this is very simple. You just go into the subtenon space and you can just go with that blunt cannula and inject. So this is a painless block. Now, what are the intraoperative challenges and techniques? Of course, the pupils are small, AC is shallow, you get posterior synec, peripheral anterior synec. You have to deal with all these problems, and surgery should be planned properly. I'll show two cases. I'll show two eyes of the same patient. In one, I have used iris hooks, and the other, I have used B-hex ring. So this is the first eye where I have used iris hooks. So you release the posterior synec. So I have planned a diamond configuration for the iris hooks, because in a square configuration, the iris gets tented and your instruments repeatedly get stuck. So iris hooks should be tightened sequentially, not all at once, because that might result in large sphincter tears. So here you see this is a diamond configuration. I am sequentially tightening this. In a square one, the iris gets tented and maneuvers become difficult. So the main port is above the plane of the iris hook. Phacoemulsification is as usual. Removing the iris hooks is straightforward. The rexus should be large enough so that you don't get post-op synec again. Viscoelastic should be removed thoroughly from the bag from behind the IOL as well. I'll show some complications of iris hooks. This is a video by Dr. Arup's hospital. So here there is iris hook has punctured the anterior capsule and there is mushrooming of fluid in this cataract. So the iris hooks are tightened too much. Now again here the iris is tented and the chopper has damaged the iris and there is bleeding. Yes, now you see the bleeding there. Sorry, I need 2 more minutes. While removing the iris hook, one part of the iris gets caught. So please be gentle in these eyes. Now this is the second eye of the same patient. Here I have used B-hex ring. B-hex ring is a disposable device which has got notches and flanges. You have to do stretch pupilloplasty, inject viscoelastic over and under the iris. And the notches have to be engaged into the iris. This was my first case, so this is very easy. This is much easier than iris hooks. Again, removing viscoelastic from the bag. So comparing the two devices, iris hooks and B-hex ring, pupil size and shape are comparable, but the shape is better in the B-hex ring. There is a little learning curve with the B-hex ring. Surgical maneuvers are easier with B-hex ring. Surgical time is also shorter with that. However, the post-op pupil size is smaller with B-hex ring compared to the iris hook, and post-op astigmatism is comparable between the two devices. Now, this PI or no PI is a question that is often asked. So clear corneal phaco with a large continuous rexus without surgical PI is the preferred technique. However, in pediatric uveitic cataracts, PI helps in preventing glaucoma. A Cochrane review has shown that acrylic IOL or heparin surface modified PMMA IOLs result in better visual outcomes and lower post-op complications than silicone or unmodified IOLs. Multifocals should best be avoided. Now, IOL or no IOL in pediatric eyes. So, post-op aphakia in younger children are associated with better long-term visual prognosis. However, if you are using acrylic IOLs or heparin-modified IOLs in good, well-controlled eyes, IOL is not a formal contraindication. And in one study, 80% eyes achieved visual acuity better than 6 by 9.5 when uveitis was quiet for at least 6 months. The most common complications that have been reported are PCO, glaucoma, and CME. Post-op complications and management. So post-op inflammation can be avoided by aggressive topical, oral, and periocular steroids. NSAIDs should be added. Posterior synecdoche can be prevented by using homatropine and keeping the pupil mobile. So the principle is to overtreat and relax, and don't undertreat uveitis and then try to catch up post-operatively. PCO and capsular phimosis are also common. So a large circular excess can prevent it. Hydrophobic acrylic IOL with square edge design is better than hydrophilic. A meticulous removal of viscoelastic and good control of post-op inflammation. Last 2 slides. Now, post-op CME, incidence of CME in uveitic eyes with well-controlled inflammation for more than 3 months is comparable to non-uveitic eyes. The risk of CME is 6.7-fold higher in eyes with previous history of CME. And CME is more common in Behçet's uveitis, and the mean period until development of CME in these eyes is 7 months. And the risk can be reduced by topical NSAIDs. So to summarize, etiological diagnosis of uveitis is key for well-controlled inflammation. The timing of the surgery should be appropriate. Don't be in a hurry to operate. Counsel regarding the visual prognosis, and intraoperative challenges can be tackled by well-planned meticulous surgery, and post-operative care is most important. Thank you.
Well, very nicely explained. You've talked all about the uveitis and cataract. All I would say is that the surgery is easy. All we need is to properly plan. The eye should be quiescent, and we should give a good peribulbar block. And do everything. There should be no shortcut. Then the results are fantastic. You also need to monitor for post-op inflammation. There are times when you can have iris Bombay formation, and patients, pressure can rise up maybe in 3-4 days after surgery. So you need to be careful at that time. That is the time when you have to do a PI, and you have to create a balance between steroids and inflammation and creation of synecdoche. That's it. Thank you.
Dr. Abhilasha, how often have you used or advised use of steroid implant, DEX implant, during the cataract surgery?
Yes, thank you, ma'am, for that question. I generally don't combine steroid implant with cataract surgery because, as I said, there is no hurry to do surgery in these cases. So if I'm planning surgery, I know beforehand. So there are cases of VKH, which can become very aggressive after cataract surgery. So I give the DEX implant about 3 to 4 weeks before surgery.
Okay.
But I don't plan it on the same time.
Okay. Thank you.